You ready? Let's do this. Hello, everyone. Welcome back to the. Oh, 1 second. I forgot my mic. 1 second. Okay, let's do that now. All right. Hello, everyone. Welcome back to the GROklahoma podcast, where we explore the incredible work shaping health research, advocacy, and clinical care in Oklahoma. Today, I'm honored to sit down with a leading expert in lactation care and maternal infant health. They have over 30 years of experience in supporting breastfeeding initiatives, shaping international lactation policies, and also leading groundbreaking research in human milk banking. She's the executive director of the Oklahoma Mother's Milk Bank. She's also an associate professor at the OU Health Sciences and a champion for maternal and infant health. Today in this episode, we'll explore her work in advocacy, impact of networking in maternal health, but we'll also hear about a fascinating case study on donut milk for children in foster care. So everyone, please join me in welcoming Becky Mannel to the podcast. Hello.
Hello, Mo. I'm honored to be here, and I'm excited to have a conversation. As my kids used to say, I can always talk about breastfeeding.
Well, we cannot wait to unpack that. So one of the things we do on the podcast is to really start at the very beginning. So if you can just tell us a little bit about how you grew up, especially some touch points in your, foundational years that will have predicted what you currently do.
Yeah, well, I started out in my former life as actually a medical technologist, and of course, I'm married to Dr. Robert Mannel. So when he was in residency, OBGYN residency, and we had our first child, that's when I discovered, and they didn't really strongly encourage you to breastfeed, but I had a sister-in-law who was encouraging me. And I once I held that baby in my arms, I'm like, oh my gosh, this I absolutely have to do. And then when I encountered problems, I realized there's no one around to help me or answer my questions. And where else is that acceptable in healthcare, that we encourage you actually, to do something that's supposedly best for the baby, but good luck, and there's nobody here to help you. Even when you're married to an OBGYN, surrounded by doctors, and none of them could answer my questions. So I guess in one sense, that made me angry and made me bound and determined that this is not happening again. So now I know that it would lead me down this path to what I'm doing right now? Never in a million years.
Wow. Thanks for sharing that. Thanks for sharing that. It's amazing how some of our pain points become our life passions, right?
Mm-hmm, mm-hmm. Right. Exactly. Personal experience can certainly, drive some of that.
Yeah. And your story also reminds me of Sydney. She was on the podcast a while ago. Her first child was diagnosed with intestinal malrotation. And because of that, she realized that she had a lot of questions. There was a misdiagnosis, medical gaslighting, and she set up a registry. And now it's ballooned into something big, children with, that condition. So thanks for that reminder. Before you, let's wind down a little bit, let's go back in time. How did you grow up? What did you grow up? A little bit about your childhood.
Well, I actually grew up in Houston, Texas, quite the metropolis. And my parents were actually professional musicians.
Oh, wow.
And then my dad also, worked two jobs. So he worked also as a public school music teacher in elementary schools in the Houston School District. So, and then fast forward to high school, and I met this young man at the school bus stop in our neighborhood. Here we are, several decades later.
Yeah.
And had gone to high school, and then we were dating while he was in medical school, and then engaged and so forth, and got married while he was still in medical school. So I've been there for all of that journey as well.
Oh, great.
Then kind of put some of my career on hold a bit. Back then, I was fortunate in being able to stay home, with our young children for about 10 or 12 years, and we were moving a lot. We were moving from, residency to then fellowship in California, and then here, to Oklahoma. So somebody had to kind of hold down the fort, and it wasn't until we got here to Oklahoma that then I was suddenly known as the breastfeeding expert by every, like, wait a minute, guys. So I realized there was now this emerging profession of lactation consultants. And I'm like, well, maybe I should look at that. That's actually quite interesting to me. So then I started, studying and working towards that. So
I had a follow-up. Thanks for sharing that, by the way. I had a follow-up question about, starting late in life. But before then, how many siblings did you have growing up, and what was your position?
I'm kind of a middle child, if you will. I have 2 older half brothers who were about 13 years older than me. They just turned 80, so now I've given away my age completely. But and they're twins, so they're hilarious. But and then that was the 3 girls who were a bit closer in age, and I was the middle one of those.
Of the cohort.
So yeah.
Great. So you talked about you had about 10 to 11 years staying home and taking care of the kids, and then the birth of your first child kind of had you have more questions, and you didn't have anyone to kind of support that, and that kind of bred your passion for lactation. For women especially women who feel like I've stayed home for a while, it's hard for me to revive a career. What are some of the tips you like to recycle on getting that started, especially if they feel like they're too old to get back into the workspace?
Yeah, well, it definitely took support from my husband and encouraging me. And when there was a position that came open for the first lactation consultant at OU Children's, he encouraged me to apply for that. I had been working part-time, and not that I was totally at home, but I'd been volunteering at a local clinic, kind of getting my experience, more informally, as a breastfeeding counselor and so forth, until I became certified. And then, he encouraged me to go and apply. And I'm like, work at the hospital? Are you crazy? And lo and behold, I got hired. I was the first lactation consultant, and that led me to, develop and build a strong lactation program at OU Children's, which I managed that for about 15 years. And so I know you had some questions on here about lactation and breastfeeding being very interdisciplinary, and I certainly discovered that, working in the hospital setting, being right there with either the newborns or the moms in, labor and delivery, or now the babies, a 27-weeker that went to the NICU. So we, of course, worked with everything.
So I had 2 follow-up questions. The first is, how does one go from a medical technologist, which is what you said you studied, to getting that certification? If you're able to talk about the steps in between.
Yeah, well, the certification for lactation consultants it's an international certification. So an IBCLC, International Board Certified Lactation Consultant, has taken the same exam in the United States as someone in Australia or Japan or Indonesia, translated in different languages. And it is actually a fairly multidisciplinary field, if you will. So we come from different backgrounds. A lot have been maybe come up through the nursing profession. My background is not in nursing, but to become, an IBCLC, you need some general college education, then lactation specific education. There's kind of 3 parts, and then clinical experience. So, and then once you've accrued all of that, then you can apply to sit for the exam. So we have, people that come from, and especially in my generation, when lactation consultants were kind of up and coming and finding out that, we were having babies and trying to do this whole breastfeeding thing, and there was nobody out there that knew anything about it. And as soon as you had a problem, well, you did it for 2 weeks, just quit. Well, no, that's not what a breastfeeding mother wants to hear.
Yeah.
Somebody to be able to
feed her baby. Yes, exactly.
Yes, exactly.
Yeah. So I imagine that, and by the way, thanks for all the work you've done so far and the work you keep doing. When you first started, and given that there wasn't a lot of people to ask around for help, and when you're the first to market, as aware, there's a lot of growing pains. People might not take you seriously and like, oh, we have to focus on other more pressing needs. And so, how did you pave that way in such a way now that all the gains you've made from your earlier work to now? Like, what were some of the tips you can maybe share on making your voice heard, especially in spaces where the voices aren't amplified?
And that's a great question, and it's challenging. And I think being a voice at the table, and not always the loudest voice,
right?
But trying to come to the table prepared and knowing what are the current perhaps current medical recommendations, what is the current medical research around a particular issue, and then listening to people, listening to whether it's other providers or health department staff or policymakers. What are the concerns, and how do we address what their concerns are as well, and not discounting them. I can remember in my early years at OU, and not everybody, physicians and nursing staff, there was a lot of education that needed to happen for the other healthcare staff in the hospital, and not just wait till, well, when Becky's available, we can go find out about that. And that's not how that works. But I remember a neonatologist at the time, being, worried about, well, if we encourage these babies to exclusively breastfeed, they're all going to get jaundice and they're all going to get readmitted to the hospital, because we had one time. One time that a baby, at that point had gotten readmitted, and it was like, okay, can we have another conversation about that and look at actually what the data says? And and yes, you're right. I don't want those babies to come back either. Right. So how do we work together to make sure that's not going to happen? Because that's not the outcome that anybody wants. And so once you come across and you validate their concerns, then they're more likely to listen to what you have to bring to the table. Yeah, I understand where you're coming from. Yes, as a pediatrician and a neonatologist, I don't want babies coming back through the emergency.
Yeah.
So.
All right. Great. Now let's talk about your work. Congrats on being the executive director of the Oklahoma Mother's Milk Bank.
Yes.
I think that's a monumental achievement. What was the journey like from idea to reality?
Oh my goodness. Starting a nonprofit, and then starting a nonprofit, in the healthcare field. Well, I think once again, just having a good knowledge of what the medical recommendations are, and working at the largest, at the Children's Hospital for the state, with the largest neonatal intensive care unit in the state, and being frustrated along with the NICU nurses and the neonatologists that, there's just times that we have preterm babies in the NICU that don't have access to own mother's milk.
Right.
And I remember one day, and this is where, once again, my husband being very supportive. I remember coming home one day and just being, really, really frustrated, because we'd had, sadly, a 12-year-old gave birth to a preterm baby that was in the NICU. And by the time I found out and wanted to go, try to talk to that mom and probably her mom about providing milk, at least pumping, she was already discharged. And I'm like, oh my gosh. And this was a tiny baby. And like, this is a baby that needs mother's milk, and we don't have any other option right now. And my husband said, well, is this when you need to try to do that donor milk stuff? I'm like, yes. Let me work on that too. But how do we get, and we didn't have a milk bank. We didn't have donor milk in the hospital. Yeah. There were, some milk banks out there that we could get donor milk from. And so that was the first piece of it, was getting with the neonatologist and saying, hey, if we actually had donor milk available, would y'all use that? Would you order that? Yes, absolutely. Yes, please figure that out. And so I wrote the proposal, did the research and the cost and everything to just at least start using donor milk. at OU Children's. So we were the first hospital in the state to even provide donor.
Wow.
And then once we had, that going, and everybody was so excited about it, and we're ordering it from a milk bank in Texas. So that helped. And everybody was like, why do we have to get it from another state?
Exactly.
Why do we have, and from Texas, no less. That's just not right.
And then the shipping, the logistics, cold chain storage, all of that. Yeah.
Yes. So then, you had enough people saying, why don't we have our own milk bank? We should have our own milk bank. And it's like, okay, let me work on that too. And I am proud to say that once our milk bank opened in 2013 and started, pasteurizing and dispensing milk, it was the 13th milk bank in the country.
Wow.
So we were not the last one for once.
Yeah, fine for once, right? Because Oklahoma sometimes,
Right.
Yeah.
But started in 2011 and, getting, nonprofit and getting a board and all. And I thought, we'll be open later this year. I just have to raise a little money.
Yeah.
Well, 2 years later.
Here we are. Yeah.
Here we are. So little naivete there at the beginning, but that's okay.
Right. Thanks for sharing that. And you've talked a lot about your husband being a peer health support. So I'm curious, for healthcare professionals, right? How can they be who want to advocate for maternal and infant health, especially when it comes to breastfeeding, advocating for breastfeeding mothers? How can they get started?
How can they get started, being an advocate? Well, I think learning, first off, educating yourself, learning what the issues are, where the gaps in care are, where the disparities are. I think we still, unless you're working with somebody that's, hands-on in maternal child health, outside of that bubble, we still as a society tend to kind of devalue women's issues. And no, this is public health. This is not just she wants to breastfeed or not, that's her deal. No, this is a public health issue, and it's bipartisan too.
Right.
So this impacts everyone. We want healthy pregnancies. We want healthy deliveries. We want, healthy babies and healthy moms after delivery. So this takes everybody. But I think educating yourself, learning what the gaps are, and then learning maybe what your strengths are in being able to either help fill those gaps or bringing the people together to recognize, well, here's the gap in care and how do we address that? Who else do we need at the table?
Right.
And listen, to all the key players. So because we learned from that too. We learned years ago, and sometimes the assumptions we make when we don't have everybody at the table. I've been on the state breastfeeding task force for WIC for a long time. And years ago, before WIC gave out breast pumps as a client benefit, we were trying to work out, the policy of how we would do that. And they had federal funds to use for pumps. And they said, if they breastfeed for 4 weeks, that's about the cost of the formula vouchers, and that will cover the cost of the pump.
Yeah.
And so there's our money to pay for the pump program. And we all thought, well, that's great. That everybody can breastfeed for 4 weeks and then come get your pump to go back to work in 2 weeks. Well, what was wrong with that assumption that we made?
Yeah.
So many women get no paid maternity leave, much less 6 weeks. So within a year, we realized this was not a good policy.
Yeah.
And we didn't have the people at the table with that perspective in the community to say, whoa, wait a minute, guys. You're all functioning from, you got private health insurance and you're going to have 6 weeks paid maternity leave, but a lot of us don't.
Don't have,
Yeah. So having the right voices at the table and learning and listening
will help. Yeah, will help. And my next set of questions for you will be more on the, interdisciplinary approach. But I think to get us there, let me bridge this question by just saying that, but just asking it this way. So I think you've hinted at it. Breastfeeding is often not widely recognized as a public health issues. And I suspect that it's because of the transient nature, right? It's only affects a specific period in a person's life. And some might even think of breastfeeding as more of a personal choice rather than a public health priority. Now, what do you think needs to change for you to be given that public health priority? And I think of it like a more of a top, down approach. What do you think is the biggest thing that needs to change so we can get that visibility that it needs?
That's a great question. I think recognizing that the process of lactation for the mother has long-term health impact on the mother. We often don't recognize the impact that breastfeeding can have on the mother. Yeah. And of course, also, we've got now decades and thousands of studies looking at the importance of breastfeeding and human milk feedings for the baby. So, how do we translate that into policy, say, from, the federal government? We certainly have had some support for quite some time now from the CDC, World Health Organization, and that, but it's still, where does the funding go? It doesn't go into, if we invested more up front in breastfeeding and lactation support, we would save down the road in preventable disease. Yeah. And so, but how do you turn that one around? Right. I wish I could say I had the answer, because I've been at
you probably be retired right now with
exactly. Yeah. But it's still just continuing to raise that flag and wave that flag and educate people, bring legislators, whether it's your state legislators on board or your federal legislators on board, and helping them. This is something positive that everybody can get behind. Yeah. And as I said, it's usually bipartisan. Everybody wants healthy pregnancies, healthy moms and babies after delivery. So, what do we need to do to make that happen? And that's what's going to set our society on, a really healthy course long term. So.
Thank you so much. As you're talking about the certification, I think IBCLC, I recall that some of my friends, so I'm a trained pharmacist, they have that certification. So I had a follow-up question for you. Breastfeeding and lactation care involves multiple disciplines, so you have your OBGYNs, your neonatologists, dietitians, and policymakers. Have there been situations where you've navigated interdisciplinary collaboration effectively? And if you're able to maybe share a story about that, and if it's led to maybe a significant policy or research breakthrough that you'd like to share with us.
Yeah, as far as that interdisciplinary collaboration.
Yes.
Well, certainly, all my years at the hospital, and working on, maybe we have policies that just impact women's services, labor and delivery, where the birthing mothers are and the newborns, but then you can have a breastfeeding mother that gets readmitted 3 months later for, cholecystectomy or something. And then now it's like, she's going to go have surgery, and she had to have a scan or something. Radiology told her to pump and dump for 3 days, or the surgeon's telling her she has to stop breastfeeding before this, so all of this. And that's when it gets tricky, because you're working with providers and healthcare staff that don't normally encounter breast patients. Right. So how do you bring all of them in? And once again, it's educating everybody about, well, here's actually what the research says. Here's what we know about this, anesthesia medication transferring into human milk, and how we're going to do this safely and preserve the breastfeeding. And we don't have to tell this mother to stop breastfeeding. So have a hospital-wide policy that everybody, can buy into and support. So that's one example. I think another kind of more on maybe the policy outside of the hospital is working to get our first law related to breastfeeding, and that was over 20 years ago. And we needed a breastfeeding in public protection. Right. Because women, I was like, guys, we actually have somebody who's breastfeeding a 3-month-old baby. Don't chase her out of the restaurant. And I'm like, do you know how many hurdles she's gone through to get to that point? We need to protect the mother's right to nurse her baby wherever she happens to be. And so once again, that was bipartisan, but we had to work with different policymakers. We had to work with with the health department, with the legislature, with other community organizations, and it was amazing how many people could say, I remember that happened to my cousin, and no, that happened to that happened to me, and I was asked to leave, and it was so upsetting, and I thought I would never breastfeed anywhere again, and so it really brought people together to recognize that this is a human right. She's just feeding her baby. She needs to be able to sit on the bench at the park, at the Festival of the Arts in Oklahoma City, and nurse her baby, and not have anybody, tell her she shouldn't be doing that in public. So that was also in a different type of interdisciplinary process. But you had to educate the police department, and you had to educate and get the health department on board with that. So.
I'm so glad to hear that that's like a distant past. The legislations around breastfeeding, because there's so many public spaces, like at the airports and in hospitals,
Yes.
even at workplaces where they have designated spaces for women to
Right.
do that. So thank you
and
all for
that's working on the federal level with the Department of Labor, and having the CDC supporting that, and also to see a lot of those.
Yeah. Now, let's talk about your case study, the one you shared with us, which I thought was fascinating stuff. So, and I'm going to put that in the show notes for people to go look at that. So you looked at the case study of a donor milk for a child in foster care. And we know that being in foster care is, if you think about the adverse childhood experiences,
Yes.
there's already a lot of other issues you have to consider. And then your case study looked at the failure to thrive. If you're able to just shed a little bit of light on what that study meant for you and your team.
That study, really, I think, showed us the power of donor milk when mother's own milk is not available.
Yeah.
And this was a baby in foster care that was failure to thrive, 4 months old, and not even on the growth curve anymore. And the foster mother was so frustrated, and had finally, she'd breastfed a little bit older baby that she had, and still had some of her milk. And finally, out of frustration, and she fed some of her own expressed milk to the baby for about 3 or 4 days. And then the baby just had this dramatic turnaround, and went back to the pediatrician, and the pediatrician like, oh man, this is great. The baby's not, throwing up, and the stools and everything. This baby's had this is a different baby. And but the baby was in foster care, and she wasn't allowed to give her milk anymore. But DHS said, well, if you can get donor milk from the milk bank, then we'll approve that. So that was a big step. And then we were happy to work with them to do that. But then, this was a baby on Medicaid, and Medicaid wasn't going to cover donor milk, because they said there's no medical need for donor milk. I'm like,
really?
I'm sorry, excuse me, this is a failure to thrive. We're trying to keep this baby out of the hospital. Well, so they wouldn't approve the donor milk, and the baby went back on, yet another type of formula, ended up in a children's hospital in the state, and was in the hospital for over a week, still failing to thrive. And this baby had now gone through 8 different types of formula, and they were discussing putting a G-tube, a gastric tube in to force feed the baby so they could send the baby home, and wasn't gaining weight. And finally the foster mother said, please, could you try some donor milk? This was a hospital that had donor milk. And they called the milk bank. I spoke to the neonatologist, or the pediatrician involved. And I said, your facility has donor milk in the NICU, and, just go get some from them. We will replenish that, but, give this baby, try some donor milk. And they did. And the baby just had a dramatic turnaround, and they sent the baby home a day later. And then we continued, and DHS was so impressed with that and glad to have the baby out of the hospital that they partnered with the milk bank to cost share and we kept that baby on donor milk for 6 months until the baby could safely transition to formula.
Right.
But we still couldn't get Medicaid, to pay for it.
Pay for that.
But Medicaid paid for 8 days in a children's hospital.
I was about to say that, and that's even way more money, taxpayers' money,
way more money,
and the impact on the child's health as well. Having to be.
Do we care about that?
Wow.
Yeah, and you think about the cost of the hospital stay and all the tests and procedures this baby had, and they were getting ready.
The foster parent having to go back and losing wages, going back and forth.
Right. But ultimately, we decided we have to write this up. This needs to be out there so we can use that to advocate for Medicaid coverage, which we actually now have.
And I love what you did with that, because it's also what we talk about on this podcast, like recursivity of research processes, how we take our findings to ensure that the knowledge we're gaining from studies is not just published or discussed in academic circles, but is actively translated into community practices, healthcare policies, public decision making. So thank you for highlighting that.
Right. I didn't need that case study on my CV. I needed that case study to get Medicaid, our healthcare authority, to listen to us.
You called them out without calling them out.
Yes.
So Becky, so I'm curious to know, in addition to just what you do at the milk bank, are there some community organizations you work with that have helped to bridge those gaps in maternal and infant healthcare?
Well, yes. In addition to a piece of my hat, of course, is serving at the milk bank. My main hat is with the university and the Oklahoma Breastfeeding Resource Center, where we've recently been awarded 2 major programmatic grants to help expand our services statewide. And then a third, as far as at least breastfeeding related, is our state breastfeeding coalition, the Coalition of Oklahoma Breastfeeding Advocates. So I actually helped found that organization too. So that's our state's nonprofit breastfeeding coalition, and they do a lot of the advocacy work and meeting with the legislators at the Capitol and working on policy, or a current issue they're working on right now is we need lactation support for incarcerated mothers.
Right.
Why can't the babies of incarcerated mothers be, why can't they provide milk for their own babies? And what can we do to facilitate that? To give you an example, that's another gap out there. So
thank you. So your spouse is an OBGYN, and he's also the director of the Cancer Center. So I'm curious to know, since your work focuses on maternal and infant health, and he leads efforts in cancer research, have there been some discussions about potential overlaps between both of your work, especially considering the how early life nutrition like breastfeeding might play a role in long-term cancer prevention?
Oh yes, many discussions, and a number of parallels. Of course, his hat is like light years larger than the hats I wear, but thinking of, and he'll be the first one to say, cancer prevention starts with breastfeeding.
Right.
He loves to say that, so he's certainly been.
That's great.
But if you think about a lot of the parallels in, and even of course, he's a huge women's health advocate, having been chair of the OB-GYN department, and then seeing impact on women's health in not just in pregnancy and OB-GYN, but bigger cancer research and prevention as well. But I work with families at the beginning of life, and he works with families at the end of life. And there's a lot of parallels there. For example, we both want family-centered care. We want the families involved, and we want the families empowered to advocate for their loved one, whether it's the mother, who's not doing so well after delivery, or the baby that's gone to the NICU or whatever. And then at the end of life, the patient that's diagnosed with cancer, and wherever they are in their cancer journey, we want the patient and the family members, we want everyone important to that patient to be involved and to be empowered to advocate for what their loved one needs.
Yeah.
So I think we see a lot of parallels in, you know, years ago. I mean, when, he early in his training is like, you didn't have dads in the delivery room. And it's like, how can you not,
Right. They both made it, it takes two.
Oh my gosh. So look how far we've come. But,
Right.
and then,
Right.
you can't talk about cancer in front of, the rest of the family, or you can't, or we're not going to tell the patient that they have cancer.
Oh, yeah. Right. Because it might distress them.
So, yeah.
The not so good old days, right?
Yes,
Uh,
exactly.
Thanks for
Exactly.
highlighting that, especially the parallels you both have, like, family-centered care. I love that. As we're winding down, I had some, tie-up questions for you. What are some key networking opportunities for professionals who are wanting to branch into this space of maternal and infant health? And what advice would you like to give them as well?
I would say, as far as networking,
Yes.
and depending on kind of, where, if they're coming from, a research standpoint versus, a clinical care or advocacy standpoint, I would say, first, whatever state you're in, find out, what organizations are working in that field. And every state has a nonprofit breastfeeding coalition, and they all belong to the U.S. Breastfeeding Committee. So that's going to be one that's going to know, where are the baby-friendly designated hospitals, and do we have lactation consultants that are, at any of those hospitals, or doing home visits, and, what about breast pumps? But then you also have, how does the health department, what is the health department doing in this space? And there's, oftentimes people get involved. I'm on the state obesity task force. Breastfeeding is, a key factor right there. So having, networking opportunities with all these people that came in, not because of maternal child health necessarily, but because of our high obesity rates. And that leads to diabetes. And then that leads to more pregnancy and birth outcomes.
Yeah.
So, but,
It's just cycle. Yeah.
Yes.
Yeah. Okay. Those are great tips. You just cycled. Rapid fire questions for you. So if you could design a billboard about lactation advocacy, what would it say?
I know, I've thought about that. And it was even, picking some brains, but I think I'm all about empowering people. And I want mothers, I want breastfeeding moms to be empowered. So I would want a billboard that says, it's your right to breastfeed and get the help you need. That they know to ask for help, and you don't have to do this alone. And oftentimes moms go home and they don't know where to go for help, and they're struggling, and they don't know we have a 24/7 breastfeeding hotline or free telehealth lactation now. And, and then if breastfeeding doesn't work out, it's their fault.
Right. Because I imagine there's a lot of shame, women feel like, if it's not working, it's my fault. I didn't do something right. I'm not eating right, or I'm not,
Exactly. We're really good at blaming ourselves.
I know. We're wired that way. Yeah. What's one misconception about breastfeeding or human milk banking that drives you crazy?
Oh, I think just still hearing from people that it's never good enough. Whether it's the mother who thinks her milk isn't good enough. And of course, we have commercial milk formula advertising that, encourages that belief. My baby would sleep through the night if I wasn't breastfeeding, or this donor milk stuff. They're not going to, that's not good enough for the preterm baby. So I think, it drives me crazy to still, hear that a lot from different directions. So
thanks for that. If you are not working in this field, what career do you think you'll have pursued? From a medical technologist to what else?
Oh my goodness. Well, it's interesting. I thought of it early on. I probably would have gone into medicine. But at the time we were dating, I had parents who worked professionally as musicians, and they were never home. I mean, they were working to keep a roof over our heads and all that. But as I got older, and I'm like, it was a big deal that they were able to come to my high school graduation, for example. And I, at the time, that was early years of women going into medicine, and I just didn't see how we could have a family and have both of us be in medicine
at the same time.
Yes. So that was a conscious choice I made at the time, and and I'm my daughter's a physician now.
That's an
So
extension of that dream. Yeah.
yes, yes,
Yeah.
yes.
What did they say? We parents' wildest dreams come true. So yeah.
Yeah, and you make choices based on, what's available what you see as the opportunities at the time.
Exactly. So
And
you're part of that as well. Yeah.
yeah.
Yeah. What's one thing that always makes you smile inside or outside of work?
Well, of course, I'm going to say babies. Anytime, not everybody smiles when they see a baby, especially getting on an airplane. I'm like,
Yeah.
oh my gosh. I smile when I see babies. But I also, here in Oklahoma, I smile anytime I see one of our beautiful sunrises or sunsets
Right.
as well. So,
Right. So we do one thing on the podcast. Finally, we have the previous guest leave a question for the next guest. I don't know who the guest is. So your question is from Sharon. She would like to ask, if you could give yourself, your younger self, one piece of advice, what would it be?
oh, if I could give my younger self, oh my goodness. I knew it all, right? No, I didn't. So, learn more and learn sooner. Yeah.
Right.
Yeah. So,
Okay. I like that. And as a way of recycling it, what would you like to pass on to the next guest, as far as a question you like to ask the next guest?
I would say, what inspires you about the work you do?
Okay. Okay.
Because if we aren't inspired by the work we do, we're not going to stick with it.
Right. Okay. I like that. Finally would be, what do you think the next 4 or 5 years would look like for lactation field? And then are there some things we should be looking at right now that we're not talking about?
What the next 4 to 5 years?
Yeah.
I think continuing to fill in those gaps. We need better support in the hospital around time of delivery. So we need more baby-friendly hospitals. That's something we've worked a lot on here in Oklahoma. And when we have baby-friendly hospitals, we actually reduce the disparity gap in breastfeeding.
Right.
So we see better outcomes amongst African American families, American Indian families. I think that's a biggie to me. And then I think just more access to care. We need paid maternity leave. Really
going into that longer time. Yeah.
Yes, but and we've got probably a dozen states now that have some form of paid maternity leave. So that pendulum is swinging, and we need it to swing all the way till we have that for everyone. So
right. And not just tied to employment. Yes,
and not tied to, well, it's my current employer, but
exactly. Wow, this was great talking to you. I've learned so much about your work and your passion, and I just think that what you've done so far in pioneering breastfeeding advocacy to leading the charge in donut milk accessibility, and that continues to shape, maternal and infant health in Oklahoma and beyond. And thank you so much for sharing all of that. And to our listeners, I hope this episode has sparked, your new perspectives on the role of lactation care, the impact of interdisciplinary collaboration, and the importance of ensuring that our work has recursivity. We're taking it back into the real world. And I love just how Becky was able to share, for example, the case study with the foster child, and how that shaped some form of policies. So thank you so much, Becky, for sharing your incredible journey and wisdom with us today.
Well, and if I can add one more thing, Mo,
sure.
I'd say when you are passionate about the work you do, it definitely makes you step out of your comfort zone. So you would not realize I'm actually quite an introverted person. But this has made me stand up in front of 1,000 people and give a talk or go to the Capitol. So I would have never, ever told you I would do that when I was in high school and college. I would have died 1,000 deaths before I spoke in public.
For the babies. You did that for the babies.
Yes. For the babies and the parents.
Yes. Thank you so much. I'll let you know
All
when
right.
the episode comes out.
Okay.
I'll share, the flyers and all of that with you. But if there's any other way we can support you and your work, you're always more than welcome to come back again on the podcast. But thank
All
you.
right. Yeah. If we have something else, we're launching our telehealth with some of our new grant funding.
Ooh.
So, that might be something that we come back and I bring Jacqueline, who runs our hotline as well.
I would
So,
love to hear that because a lot of AI telehealth, accessibility, especially in rural areas, have been coming up with Medicaid expansion. We should
yes.
make that a day. Whenever you guys are ready, please,
Yeah.
consider us as your platform for that.
Oh, we'd love that. So
All right.
awesome.
And
Awesome.
thanks for your
All
quick
right.
response. Enjoy
All
the
right.
rest of your day.
Okay. All
All
righty.
right. Bye. All right, everyone. That was the GROklahoma podcast. I'm really happy tuning in today. You all tuning in today. If you've enjoyed this episode, please don't hesitate to share it with your contacts. If you'd like to feature on the podcast, I'm making a call out for anyone who does work in clinical and transitional research. We're taking everyone across the spectrum, support staff, faculty, PI, postdoc, students. So until next time, stay curious, stay engaged, and keep growing with GROklahoma. Bye for now.